Okay, I think we have sound. I've unmuted Queens. I see the talking's working. I've clicked the record so we can have a copy of this. And it's 12 noon, and I'm so excited to see all the folks that have gathered here within Queens Conference Center auditorium. And quite a few are gathering online. So welcome everybody. I'm Valerie Yantz. And we are sponsoring this training today in conjunction with Mental Health America of Hawaii. And the trainer today is Tricia Kajimura, and she is kind enough to do this training for us. So the title is Mental Wellness, Mental Health Screening Tools and Solutions. I've seen the slides, and I think we're going to have a fabulous training today. And the organizers are the three of us, and there is a steering committee of about 14 members who run the public health training HUI, and we started many years ago trying to keep the network working as a group so we wouldn't repeat our trainings and we could share our resources. We are also a member of the Western Region Public Health Training Center, which involves 4 states, us, Arizona, Nevada, and California, and the Pacific Islands. And the exciting thing that I have announced now for the last couple of months, we got a renewal from the federal government through HRSA for another 4 years of training. So we're very excited that these trainings can continue. And then the sponsors and partners are the HUI, as I explained, and I work at the University of Hawaii at the Office of Public Health Studies, the Western Region. And there are 10 regions in this nation, the way the feds, and so the black one there is the Public Health Learning Network. We're all a member of that, and thanks to Queens Medical Center because they allow us to use this wonderful conference center. Eleanor Huey is my partner at Queens that helps us do it, secure this site. The other thing that most of you are happy to hear is that we do obtain continuing ed credits, and this is thanks to folks at the University of Arizona, to the local National Association of Social Workers, our own Department of Health for the certified substance abuse counselors. We also do the certified health education specialists, or CHES as we call it. The registered dietitians are the ones that we get through Arizona's help, and the nursing. So we really help a lot of people keep their continuing ed. These are the competencies that cut across the different disciplines. We're going to learn a lot, number 2, about resources and strategies. And I know Tricia and how she handles, she has very dynamic way that she deals with diversity, because as you will see, there are many different mental health concerns that you can screen for. So there's quite a bit of diversity of who needs the help and which mental health concern resources might be available. You can read the rest for the other continuing ed competencies. If you're requesting continuing ed, Camille, if you need to do at a minimum 2 things. Attend the entire webinar. At the end, Camille gets on during her lunch period and is ready to email the survey for everybody to do the feedback, and we compile that and use that to keep our funding going. And then she, if you do that, you will get a certificate from her within the next 2 weeks. There are extra instructions for nursing. These are the learning objectives for today. Tricia will be talking about the tools, results, and recommendations from screening results, and then she's going to take us into Hawaii-based resources. And she and all of us partners have no financial relationship to disclose. And for the nursing, which are called CNEs, there is this special link here. I will put it in the chat for all of you online. I know several of you are having a hard time getting the handouts. We do it through UH file drop, and somebody clicked this morning at 4:28 the expire AM, the expired button, and then nobody else can access it. So I reloaded them into a new link. I've already put it in the chat. So if you're just joining, you know, click on the chat and look at the top of the chat for the links. But the link here is for what nurses have to do, part 2, to get their continuing ed. The same thing happens for CHES. Well, when you click the nursing, this is what it will look like when you go to that site. The CHES will also have to click a second link and fill out this survey. So both of those continuing ed have extra steps. Most of you have already been acclimated to it, and if you don't know what to do, you usually email Camille or I, and we will guide you in that. We are on Zoom. Most of you have downloaded the Zoom software that you need, and we do record it, and here's the YouTube link if you want to listen to the recordings. Online, you should get 4 handouts: the PDF of the PowerPoint, the CHES instructions, the nursing instructions, and next week's flyer. Here we have a color-coded handout. The blue ones, would you please fill out those here in the room for the evaluation. Those online will get the survey from Camille right after the training's over. So now let's get to the good stuff. Tricia Kazumura is, we've been professional friends for a long time, and she got her master's in public health from the University of Hawaii, Manoa, and she has gone on to create a fabulous career. She is now currently the Executive Director of Mental Health America of Hawaii since 2016, and they have so many activities. If you have a chance, please go to their website. They're really doing exciting things in Hawaii around mental health, and then they're connected to their national network of mental health, so they really have wonderful resources, as you will see. She used to work at Catholic Charities as their social policy director. She has a strong policy background, and she worked for Life Foundation and in HIV care service director, and she serves on all of the boards here, including the one with us at the University of Hawaii Office of Public Health Studies, our advisory board. And this is her presentation: mental wellness, mental health screening tools and solutions. Thank you, Tricia, for being willing to present today. Yay.
All right. Thank you so much, everyone, for being here. Good afternoon. It's wonderful to see you, and also hi to all of our friends online and on the phone. Thanks, Valerie, also for always so supportive with everything that I'm doing professionally and with our organization as well. We really value this partnership because it gives us such a great opportunity to promote our mission and to get mental health information out into the community, and especially to people who we know are going to use it. So today we're talking about mental health screening tools and an online program from Mental Health America that's giving us some insights and data to inform what we do as individuals, advocates, practitioners of various disciplines, and even for self-care and our own personal practices. I'm hoping that there will be some new information in this presentation, even for those of you who are very experienced in screening. I've been learning a lot from it. One caveat is that I'm not a clinician. I don't have any clinical training, but as Valerie mentioned, my background is in public health, advocacy, and social services. If you have any questions that are more on the clinical side of things, I'd be happy to take them and get back to you with answers from our professional consultants. We also, I think for the sake of people joining us online and on the phone, there will be Q&A at the end instead of during the presentation. So our mission at Mental Health America of Hawaii is to serve our community by promoting mental wellness through advocacy, education, and service. I'll be filling in some of those details in a bit, but just to give you a little context for today's training. Here's our agenda. So I'm going to tell you more about us. then get into the mental health screening, starting with the need in our community for mental health services and education of all kinds. We'll also talk about why screening is important, specifically about Mental Health America, which also known as MHA, MHA's online screening program, its 2017 results, and some of the next steps that we're looking at. So Mental Health America of Hawaii started in 1942. Not everybody knows that we are that old, 76 years old now. And we're started by socially conscious volunteers who wanted to improve the care and treatment of people institutionalized for mental illness. So at that time, we were called the Mental Hygiene Association of Hawaii. And we worked on issues such as deinstitutionalization, suicide prevention, and crisis intervention. For a long time, and fairly recently, we were known as the Mental Health Association in Hawaii. I bring that up because some people, that connects the dots for some people who knew us more by that name. So we're an affiliate of Mental Health America, which means that we're an independent local 501c3 governed by a local board of directors. We don't receive any financial support from Mental Health America, but we do benefit from their federal advocacy, their research, reports, toolkits, and programs, some of which I'll be sharing with you. And we definitely need their leadership in Washington, D.C. so that we can focus on what's happening locally. Some of you may have been fortunate enough to hear our national president and CEO, Paul Gianfrido, speak a couple of times earlier this year and last year when he visited us. And if you didn't get the chance, he's someone you might want to check out online and follow on Twitter. He has YouTube videos of talks. There's the Mental Health America website. He's really a great resource and somebody to pay attention to. So with advocacy and education being our main focus, here's a list of the education-focused initiatives we have. And here's a list of some of our advocacy efforts. Our team, most of our team is here. We're 7 people strong, 6 on Oahu and 1 on Maui. We're always happy to talk to you about what we do, so please don't hesitate to ask us today or in the future if there's anything you want to know more about, such as how to attend or request one of our trainings or how to get more involved with advocacy. But today we're going to focus on mental health screening, starting with the need. And I'm sure that the work you do and the situations you encounter every day make you all painfully aware of the need for help when it comes to mental health in the areas of prevention, education, treatment, and more. So even though I know you're all very familiar with those facts, I'm still going to take you through some of the statistics because they never fail to alarm, right? And they remind us and give us a greater sense of urgency for the work that we're doing and the impact we're trying to have. There are a couple of key reports that we reference for our statistics. The first one here, and I provided the link, is the State of Mental Health in America, an annual report done by MHA. And it gives state-by-state comparisons on a multitude of indicators. So here we have the most basic of statistics, the one that we use a lot, the 1 in 5, or 20% of adults in the US have any type of mental illness, to illustrate how common it is and also bring up the question of why do we have such a hard time talking about it and dealing with it? Why is there so much stigma around something that's so common? But you also see here that only 36% of those who have a mental health condition receive any type of treatment. To me, that's one of the most compelling statistics for why we need to work on reducing stigma, on making services more available, and on educating the public, everyone. The next report that we looked at recently is the Commonwealth Fund Health System 2018 State Scorecard. So also a state-by-state comparison report. And so you see here that children who did not receive needed mental health treatment in 2016 were 23% of those identified with need, national average being 18%. These are Hawaii-specific statistics. Adults with any mental illness reporting unmet need, 14%. Adults with any mental illness who did not receive treatment, 64%. So that matches the statistic on the previous slide. Here are some Hawaii youth mental health related statistics. So on the left side is from CAMD, our Child and Adolescent Mental Health Division of the Hawaii State Department of Health. Their annual evaluation summary shows us a breakdown of the primary diagnoses for adolescents in our state. That's just for your information. And then on the right, from the Mental Health America report, it shows that 6 out of 10 youth with a major depressive episode did not receive any mental health treatment for it in 2017, which puts them at risk, right, for poor performance at school, trouble in their relationships at home and with friends and their peers, and also putting them at risk for suicide. Looking at some suicide statistics, right? In Hawaii, suicide is the second leading cause of death for ages 15 to 34, and it's the leading cause of injury death for most of our adult age groups. On the right side, some breakdown on location, gender. There are higher incidents of suicide on the neighbor islands than Oahu. Males have a higher fatality rate. And then in thinking about the impact of suicide, it's important to keep in mind that for every death, there were hospitalizations, ER visits, a higher number of attempts than deaths, and many people affected by either the suicide attempts, suicidal ideation, or deaths of their loved ones and acquaintances, whether it's people at work, family members, friends. It has a really wide effect on a community. So why screening? This particular slide comes from Mental Health America, specifically our national organization. Screening is an established practice. I'm sure many of you have been involved with it for a long time, but Mental Health America has made it part of its Before Stage 4 platform. So we talk about other diseases, most commonly cancer, in terms of stages, but with mental health, we do nothing until a person is very far along, right? Most commonly, not always, but often not until somebody is in what you could consider stage 4. So Mental Health America really wants us to look at what can we do before things get so far along. And the Before Stage 4 philosophy is meant to draw attention to the fact that we have many opportunities to prevent and intervene in mental illness before we get to a stage 4 event, such as a suicide attempt. Mental Health America is challenging all of us, and particularly our policymakers, to think more about prevention of mental health problems, what that looks like, and what that takes. The Before Stage 4 philosophy is summed up in these 4 quadrants of this graph. So prevention services for all, early identification and intervention for those at risk, prompt, quality integrated services and care for those who need it, with recovery always as the goal. Mental health screening in this philosophy falls in the prevention quadrant. Certainly it can be used and should be used for people who are at risk or people who are suffering from mental illness, but it is a very powerful prevention tool. So research has found that the use of screens in healthcare has led to measurable positive outcomes. People who screen regularly are more attuned to their symptoms, more knowledgeable about their conditions, better able to communicate with their providers, able to recognize improvement early in treatment, more aware of the warning signs of relapse, and better able to self-manage their illness. More screening also leads to better health care. So ideally, screening becomes integrated into primary or even behavioral health services. Screening in primary care perceived as helpful 93% of the time. Primary care physicians are 3 times more likely to recognize mental health illness symptoms and follow-up when they screen their patients. Post-screening, treatment changes were made 40% of the time, and the positive benefits were found to persist 1 year later. So let's look at Mental Health America's online screening program, which is called Screening to Supports. The idea is not only to screen, but also to offer information and supports for those who are willing to take another step. What this platform does is it puts the most commonly used screens in one easy place to access, and it also generates data that we can work with. So this is what the homepage of the program looks like. And if you click Start by taking a screen. So what I have here are screenshots. You're welcome to bring this up on your devices if you'd like, so you can even play with it as I'm speaking. It's available at that link, screening.mentalhealthamerica.net. If you Google mental health screening, it'll probably be the first item that comes up. So if you do that and then you click on Start by taking a screen, this is where it takes you. Not sure if that's difficult to see. The words are kind of small. But you get 9 validated tests and 1 survey, which I'll tell you a little bit more about. Now from the home page, if you scroll down, it would take you here where you can get more information in these different categories. And this is more of that as well. That's further down the page. So lots of information on different mental health conditions, tools that you can work with yourself, different types of treatments, various types of information. So returning to the screening page, here are the available screens. The work health survey, which is on the bottom right, is not a screen. It's a data gathering tool positioned here in case any visitors want to help out MHA by taking it. If you do choose to take the work health survey, it looks like this on the left side. It's just a quick survey, and it generates, the data is used to generate this report, Mind the Workplace, or a workplace mental health report that MHA puts out every year. But here's a list of the actual screens that are on the screening page. So these are all validated tools that many clinicians currently work with. MHA chose them carefully and obviously carefully vetted their choices. So choosing a sample screen, I chose depression or the PHQ-9, which is a very common screen for depression that I'm sure many of you are familiar with. Many physicians work in a couple of these questions to their primary care visits to see if their patients should be assessed further for depression. Depression is also one of our most common and pervasive mental health issues, which even though it's common, we shouldn't take it for granted because it is one of the biggest risk factors for suicide. So we want to take depression very seriously. It's treatable. There's a number of different ways to treat it. This is just a sample of the screens. Out of the 9, I chose this one. And I chose the answer more than half the days for each question that they asked. Okay. So you can answer the screen however you want or however is appropriate. One thing I wanted to point out is that the online screening program is completely anonymous. So no user data of any kind is collected, and that is so people feel safe taking the tests. It does have another consequence, which is that we can't follow up with anyone. So anyone who takes a screen and needs further intervention, it's up to them if they want to follow up with any of the resources that are offered to them. MHA decided that anonymity was important beyond any of the other considerations for all of those reasons. But if you click next after the screen, then the demographic information on the right side pops up. And it's optional to fill out this page, but also critical for further analysis of the results. So we hope people will fill this out, but they're not obligated to. And then after that comes the result. So in this case, the result was moderately severe depression. They give a summary of what that means. And you can click on your answers to review how you had answered the screen if you wanted to make any changes for any reason. And then an interpretation of the score option comes up as well. So if you click on interpretation of the score, you get this, which tells you what the results of the PHQ-9 mean. And if you'd like to monitor how severe your depression is over time, they have suggestions for taking it in another 2 weeks, discussing it with somebody who can help you in your recovery, such as your doctor, and you can also have the option to print or email your results. If you scroll down further from this same page, you'll have these options to look at. So in the future, we're going to be able to add local resources here so that people are not just limited to online resources, but will also have options of places they can call or seek help for further information. Now that was our sample screen. So let's take a look at the 2017 results of the entire screening program. Nationally, over 1,064,000 screens were taken. Of people who marked that they were from Hawaii, there were only 2,192. So I'm going to show you a comparison of results, but just keep in mind how small the Hawaii numbers were. And so we're not sure at this point how statistically significant it is, but we're still going to use the results to guide us in what we do next. So these are the types of screens nationally versus Hawaii that were taken. Orange is national, blue is Hawaii. You'll see that Hawaii, it's basically the same. Hawaii was a little higher and lower in some, there's some variation. But overall, the emphasis was on depression, bipolar, psychosis, and anxiety. The gender breakdown, very similar between Hawaii and national screeners. The race ethnicity breakdown, of course, is very different. So this does reflect a Hawaii audience where Asian Pacific Islander population is much larger, white non-Hispanic is much smaller, more than one of the above option is larger, and the African American portion is a lot smaller. So Hawaii ethnicity race is very different from national. Screenings lined up with national for them largely, with the group on the far left being the 11 to 17 age group. So that tells us that it's really young people who are utilizing this tool. 11, 17 is the largest, and then 18 to 24 is the next largest, and it goes down from there. And what we also can kind of get from this is these might be youth who are not seeking this information or help elsewhere. This is something they can do on their own without their parents' knowledge. They're seeking information and help for whatever reason, and something that we need to pay attention to. This question was, are you currently or have you ever been diagnosed with a mental health condition or addiction by a professional? The larger portions, both nationally and locally, with locally being larger at 72% versus national at 64%, say no, they've never been diagnosed with a mental health condition by a professional. So that tells us also that these are folks who may have never received treatment, probably never received treatment, might need it, and are looking for ways to get the help without talking directly to someone. So these are probably first approaches into seeking help. And then what next steps do you plan to take after screening? Largest proportion, none at this time, with Hawaii having a slightly higher proportion than national. Next step, discuss results with family, friend, or professional. Then find additional information online, find treatment. Small proportion say monitor my health by taking screens regularly. So again, something to be concerned about here with people not planning to take further steps. Students, by far the largest of the special populations using this tool. LGBTQ persons, next. Now looking at some of the individual screen results, folks who are taking alcohol or substance use screens have high positive results. Okay, so people are taking these screens, realizing they might have a problem checking in, and the screens are confirming that yes, you should look into it. So our help-seeking population indeed needs help. Anxiety screening, highest results in severe, and then it goes down the severity scale. But people who are taking the screens for anxiety do look like they're suffering from anxiety. Same with bipolar, although national negative results are higher than positive. Depression, severe and moderately severe are high, moderate depression also high. In some sense, this does tell us that the program is reaching the people who need it, and that's a good thing. Eating disorder screening at risk is 95% in Hawaii, 91% national. Parent screening, which is a parent screening regarding their child, scoring high for at risk, so high positives. Youth screening is about 50-50, which is quite different from national. National positive is much higher, 74% versus 48% in Hawaii. The next set of slides are advanced analysis specifically of the national data, because they have such a larger pool to work with. I took these slides directly from MHA. And screening results indeed show that men are more likely to do nothing than women. So gender concerns are valid. Caregivers who take the eating disorder screen are most frequently positive for the eating disorder. So if you can see, this graph is of results for people who indicate that they're caregivers of some kind. So it goes down from eating disorder, their eating disorder screens having the highest positive result, parent screen, PTSD, depression, substance abuse, anxiety, psychosis, youth bipolar. And Native American and multiracial individuals, most positive or most severe in 2017. Women under 25 are more likely to have positive results versus men under 25. And they also show that screeners with chronic conditions, so comorbidities, positive for mental illness at these rates. So folks without Alzheimer's taking our screens are coming up 79% with a positive result. Folks with cancer who are taking a screen, 74% with a positive result. Chronic pain, 78%. Diabetes, 74%. COPD, 79%. So this speaks to medical complexity. The folks that our physicians and medical staff, healthcare staff are working with, the complexity of the issues and sorting out the physical from the behavioral health concerns. And then amongst our LGBTQ youth, on the national level, they are also showing higher risks for various things, including 81% screen positive. They're more likely to take the youth screen and psychosis screen than those who don't identify as LGBT on the screens. They're less likely to discuss the results and more interested in doing nothing than their peers who are not identifying as LGBT. One small spot of hope, I think, is with our millennial population who are taking these screens. So of the 2017 screens, nearly 1.1 million were in the millennial age category. I'm sorry, the total amount of screens was about 1.1 million. Of that, half were of those who reported in age were in the millennial generation. And compared to the national average, they're more likely to find treatment, more likely to take a next step. And to me, hopefully what this means is stigma is breaking down somewhat with the new generation, which is anecdotally what we're seeing and believing with trends in social media, in the way things are reported, in what TV shows are showing, all of pop culture. Hopefully that they're starting to set a new trend for even younger people around stigma, discussion of mental health issues, and being open about them. Of the special population of new or expecting mothers, when you compare them to the national average, they're more likely to screen likely substance use in the substance use screen. They're more interested in discussing the results with someone else, more likely to find treatment, and more likely to have comorbid health problems. So this is something for people working with expecting or new moms to look at. What are we going to do with these results, and why is MHA putting so much time and effort into this program? So what I think that the high numbers of screens can give us with the results are new insights into the populations taking the screens, which are help-seeking populations, people seeking out this type of information, who are also, for large part, the result was around 75% never diagnosed. How do we reach these folks, and what kind of information is going to help them to follow up or improve their self-care? Then planning and evaluation, MHA can give us special URLs for population tracking, so they can, like you saw, pull out Hawaii-specific data. They could, hopefully when we have higher numbers, they can pull out Hawaii-specific data on the special populations like veterans, students, new moms, those types of populations that they're asking about in the demographic section. And then we can start anticipating the needs of individuals and delivering targeted services based on what this data tells us. There's a lot of potential use for it, some of which we are already doing. So grant applications, using them in our communications, helping us with needs assessments to identify the needs of our community, program evaluation, public education campaigns, and targeted programs. I think we can be as creative. It's only limited by our own creativity as to how we can use this data. But one of the most important things I think we need to ground us is that each person taking us, to keep in mind, right, that each person taking a screen is somebody who is looking for help. And these are the things they're looking for. All of these words paint a very compelling picture of what people in our community are suffering from, what they're lacking, and what they're looking for. And so how do we, as providers, as social service agencies, get this information and help to them in a way that's accessible, inviting, culturally responsive, and easy for them to accept? And that's, I think, the bigger picture that we're all working on, and that the vision that we want to have for not just our state and but each individual who needs help, because the suffering at an individual level when you can't find help is so acute, and sometimes, most times, unnecessary if we can get them the right intervention. So what can you do with this information? Well, I hope that you might have some ideas of your own in hearing about this program. But what we hope that people will do is incorporate screening into their practices, whatever they may be. Encourage people to use follow-up intervals if it's helpful to them. Let us know if your organization should be listed as a support resource to online screeners. So that's the screening to supports title that I mentioned in the beginning. We have the screening part. Now we need to get in more support. There's a lot of online resources that they're being referred to, but sometimes people want a live voice at the end of the phone in their own community. So that would be the next step, is getting that information into the program. We'd love it if you would list our screening program as a resource for your program or patients. You can direct them to our homepage. And for you to join our our advocacy efforts. But most of all, to help us normalize the topic of mental health, because we think that right now that is what will make the biggest difference. If people feel safe in seeking help, feel free from judgment, stigma, all of those barriers to seeking help and receiving treatment, that will make the biggest difference. Thank you all very much for what you do individually and for being here, because I know that shows that you're interested in this topic and what you can do to promote mental health in Hawaii. I wanted to share these resources that we have. So at our office, we take help calls from the community during our office hours. So those are the hours and our phone number right there. And what we do is we share possible next steps with people who call. So we take calls from anyone, professionals, to consumers, to just somebody who found our phone number somewhere. We answer a variety of questions and try to provide that connection that can help them. Our website has a lot of resources. Our website is at mentalhealthhawaii.org. And if you see the top right, the Finding Help box, so that's the name of our Human Services Directory, which we're passing out in the lobby. It's available in hard copy. You can request us to mail you a few, or you can come to our office to pick some up. But it's also available on our website. If you click on Help, there will be a PDF available for your use. It's also available in PDF form or searchable form on our suicide prevention app, which is called Kokua Life. It's available on iTunes and the Google Play Store. And you can go to kukualife.org for an easy way to download it. So it's free, and it provides different categories of suicide prevention information that you can have in an app right on your phone. It will also has links to the crisis lines and to 911. So it's a great resource whether you want it for somebody close to you or yourself, or if you just need it as an informational resource because of the work you do or the people you interact with. It's a great way to have it in one place and right there in your hand on your phone. So that's available now. And there's a searchable directory link on there as well. mentalhealthamerica.net is the national organization's website, and there is my email address. If you have any follow-up questions, I would be happy to answer them or find somebody who can. So that's the end of my formal presentation, or and Val, if you're ready for questions, I would be happy to take them.
Sure. And I have several online, but I will take one from the audience here in the auditorium, or shall I start reading the ones online? Anybody want to lead off with a question? We just need to use the mic so all the online people. So one of the first questions that came in was asking about your dad, Tricia, and it was a very thoughtful one. Let me read it from several down here. I'm wondering to what degree these statistics are influenced by greater contextual factors, i.e. professional culture, culture of origin, social norms, etc., and how much they encourage versus discourage help seeking for working adults, particularly older adults, just thinking out loud. Do you have anything to say to that?
Were they, I'm not sure if they're referring to the statistics in the report, but probably the statistics,
I think the
data from
country
the
one,
screens,
it came in
right?
when you were for the whole country.
Mm-hmm.
Does that help? So I think she's just wondering about the degree that they're influenced by contextual factors.
So the national data, it's difficult to say because it is national data. I think that in other, it can be broken down by states, which would tell us more about context. So I'm sure they are influenced. I'm not sure how to break it down just based on what we have Sorry. But I'd be happy to take a more specific question over email if she wants to follow up.
Okay. Yeah, so please take note of the email on this slide, Miyumi. This one is from Donna. What if a social worker has a client complete a screening and the screening should be, quote, positive? What does HMA recommend the course of action be?
I think it depends on the setting of the social worker, and that brings up a good point. Something I didn't say was that this is not assessment, this is screening. So there's definitely more evaluation that needs to happen. So they should be referred to a mental health professional or medical professional, healthcare professional, whether it's their PCP, and then their PCP can decide where to send them, or if they're already in a behavioral health setting, to bring in one of the clinicians for further assessment.
Good. Would MHA consider including a screening tool for adverse childhood experiences since it correlates with mental and physical health?
That's a great question. I would definitely look into that with National. I would be happy to follow up with National on that. What actually came up in a conference that I went to in June was other MHA affiliates like us were asking for a suicide risk screening to be added. And that's something that they're already considering. Nobody brought up an ACE scale, but that's a great idea.
Okay, and more questions are coming in. Kathy was wondering about who to contact in Nevada. So because we have this regional blast, we are getting some mainland. And thank you, Kathy. If you're in Nevada, I know it's a little later in the day. So does she go to, is there Mental Health America in Nevada?
I hope so. I believe there is. I can definitely find out.
Okay. So then Donna's back. Let me see if this is the same. Yeah, it's sort of, you anticipated. Donna's back. What resources are available to a social worker in supporting them in being more comfortable in talking with a client about suicidal thoughts?
So, what resources are available? We're a member of the Prevent Suicide Hawaii Task Force, and that's where I think the best information locally is about suicide prevention and safe messaging, how to talk to people. I would imagine there's training available as a social worker through those channels, but I'd be happy to follow up with her on that as well.
Yes, and you know, I work with Jane Chung Do and Jeanette Sujimoto Matsuda, and they do a lot of youth suicide prevention. So does Judith Clark at Hawaii Youth Action Network. So I think there are a lot of suicide prevention groups to link them with. Okay, we'll try to follow up with that. Holly is saying, mahalo, Tricia, for your excellent presentation. Can you speak about MHA, what MHA is offering to the Big Island community affected by the volcano?
One thing with neighbor island communities, we're based here and we have a small office on Maui. It's important for us to be invited to serve on the neighbor islands that we're not currently connected with. So we've been invited to Hawaii Island to deliver our youth suicide and bullying prevention training fairly recently. We haven't been invited to work with the community affected by the the recent eruptions, but we would be happy to look into it.
Okay. Another question, I'm checking out the Kokua app now, which is great. Do you know offhand if the crisis line of Hawaii's number is listed for CMO? CMO is a mobile program that responds to youth and adults on the outer island like Kauai and Big Island and responds to mental health crises, which looks like suicide. CMO is 24/7 and comes out of schools, ERs, and homes. A good resource to have included if not on there now. I think
That's
she's
definitely in the directory.
Yeah, okay, good. Great. But here's from Melissa. Have there been any thoughts about coordinating with ASIST, they're all in caps, Assist for Suicide First, Mental Health, and Mental Health First Aid, which are being used in DOE?
Yes, we have certified trainers right now for youth mental health first aid. We're working on adult certification, and we have some of our staff have taken the Assist training, although we're not certified to deliver that training at this time. But we can certainly connect people with the trainers for Assist.
Yes, and somebody's commenting that the mental health first aid is a great training both for adults and youth. So thank you for advocating for that. Here's somebody from Arizona here. I'm about to begin Monday a university position working with first generation STEM students and know that our intake will cover lots of ground. However, are you aware of any higher ed screening tools tailored to a college audience? It also sounds like, thank you, Melissa and Celeste, that Assist and mental health first aid would be helpful in my future position. Do you have anything else for this woman? I think it's a woman with a new position.
So there's definitely Mental Health America of Arizona. I've met them. I think the MHA screening program is perfect for college students. And there could be college-related specific resources there as well. We're working on something here, has a really local focus.
Yes, okay. I am not getting any more typed right at this time. Anybody in the audience like to ask a question? Coming down with the mic, just hang on.
I had a question in a different angle around the mental wellness, and I was wondering if meditation or mindfulness is being used, and how and with whom and at what level.
So within the screening program, some of those DIY tools, the other resources offered besides the screenings themselves include that type of information and also links to online resources for that.
Anybody else? So Trish, I have a question. In preparing for this training, I went on to your website and I don't think I clicked every screening tool, but I did about 4 of them just to see what the questions were and how I felt about taking it if I was a participant. And I was very impressed. One, it was so easy. You know, sometimes you have to log in or give a whole bunch of information before you use the screening tool. So I really liked how accessible they were without having to, you know, that you could pretty much stay anonymous. So I think that's a great strength for these. And I like what the social worker was saying, that they could go on and say, let's just go through this screening together, and because they ask good questions and it allows us to talk. So I think it's a really good tool to use with any helping person, a caregiver, a health professional, a counselor, a substance abuse counselor, whatever. So I was very impressed with that. And then the one that I had been helping, because I teach, helping a student, the depression one, I did this as I imagined the student might answer it and got the score. And could you tease out a little more, because then it sort of tips it either way. Yes, I really am depressed. Now what am I going to do? Or I see I answered some of these as I'm partially depressed, but I'm not completely depressed, or I don't know where I am. So there's kind of that nowhere land after you take the tool. I'm glad there's so many resources, but could you just tease that out a little bit, what the intent was, how does the individual think about it after they realize that there might be something going on? And then like the men who don't want to do anything, oh, it doesn't look good. I'll just ignore it. I'll deny it.
Right. So if I want to make sure I understand what you're asking. So taking a screen and it being a little inconclusive and not being sure what to do next?
That's one angle. Or what was envisioned with these screening tools? How can we really move them forward? I just think they're marvelous.
Well, yeah, definitely the vision is that people take next steps, right? So people get information, some validation maybe that what they're feeling is measurable. It's showing up when you take a test, and using that to help convince them to possibly take a next step. So that's what the screening tool supports. That information is meant to provide options for people. So, you know, also important to keep in mind that a screen result doesn't mean, yes, you're depressed. You still need to consult with a professional, but it can confirm like, yeah, like something's not right. And it will give you information about steps that you can take, whether it's changing your physical activity. It'll ask you about sleep, take a look at your sleeping habits, who you're spending time with, you know, work versus self-care time, those types of things. So because some of it comes under the category of DIY. And if somebody tries that for a while and then they decide to take another screen, maybe the next set of results will help them to take the next step into talking to their doctor or finding somebody to give them the next step after that.
Good. Yeah, and I'm trying to get people to think about this because it's a marvelous tool.
Thanks so much for the presentation. I'm wondering about the local crisis line, hotline. Over the years, it's been more or less accessible, you know, as far as staffing is concerned. I haven't had the need to direct someone to it recently, so I'm just wondering what its current status is, what its funding levels are like, if that's something politicians need to hear more about.
No, I'm just trying to think if I should toss that to someone sitting in the audience. Jerry. So so the crisis line here is really divided into two. There's the actual crisis line with response, and there's the assessment line. It used to be one. So if you're looking for case management services, you have to call the assessment line. I don't know if I have the name right, if it's a crisis situation. But Jerry, Jerry takes a lot of those calls for us. Everybody say hi to Jerry.
Hi. So in terms of crisis, it is manned, and I know in the past there were people that were put on hold or weren't directly connected, but now everybody I've talked to, they have actually talked to a live person when they called. The reason they're calling me is because they are assessed through the phone call, and when they're doing the assessment, they're assessed at not a danger to themselves or to others. So then they're referred to us to try to connect them to services, to give them local resources, local phone numbers to call. So it's good at handling crisis. In other words, nobody is getting placed on hold, and they are talking to people that are assessing them. So that being said, I guess it's very effective for crisis when somebody is at the point where they're going to harm themselves or others, but it's not effective as a tool for somebody who may be depressed or needs to be connected to services. They may be, like forwarded to the assessment line, but we're still getting calls from people that don't fit into crisis or assessment.
Thanks, Jerry.
Yeah, so this is a gray area. So, the wonderful thing is that this step has been taken, and there's the the call line, and then finding the right provider is always a challenge.
Hi, I have one comment to make. The people that we work with, often because they're attached to the prison system, they can't be signed up for MedQuest. So when we first get them, and they are more open to maybe seeking professional help, there's no place we can go, because providers expect to be paid. I would expect to be paid. I'm not slamming people for expecting payment for their services, but there's really nowhere we can refer anybody to. And the population I work with, most of them have severe lifespan trauma and substance history, things that are really complicated. So that's another barrier that I'm finding with the people I work with. And then once they get medical insurance, they're so busy with, they just want to go to work, do this, do this. So then when I talk to people, what we have a hard time doing is even finding a provider, because all they are names. And the people we work with, a lot of therapists also are one person, and our population doesn't like answering machines. So if they get answering machines, they don't even want to leave a message or anything. So because you can't solve my first problem, which is allowing maybe inmates or people to access state medical or something, what about finding a therapist for people who may be open to it, but we have no clue who to, especially people who work with trauma and dual diagnosis?
That's something that we could work with you on. I'd like to know more about that. If you don't mind hanging out, and we'll exchange information. Thanks.
Anybody else? Let me go check online. Did you want to say anything, Tricia, while I'm walking back here?
No, I want you to sing a song, Valerie.
Yeah, there's some more here. Holly, is there a follow-up system post-screening for those who measure high on any specific scale? We've already started to touch this. For example, a push message that might go out to various intervals, 5-day post-screening, 3 weeks, to the individual as another prompt to encourage follow-up with a mental health.
Yeah, it doesn't, the system doesn't collect any information that would allow it to follow up. You don't enter an email address or anything like that.
Yeah, okay.
They deliberately chose anonymity over the ability to do those things, even though, it's definitely.
Right. Yes, so somebody mentioned the crisis number. They're asking, what is the crisis line number? Is Crisis of Hawaii or something else?
Yeah, Crisis Line of Hawaii. They want the number?
Yes.
Okay, I'll get that.
And then Naomi is following up on her comment. I guess what I was pointing to in my original comment is how we encourage employers, family members, community leaders, etc., to support screening, make treatment accessible in industry and trade, community, families, where typically treatment is undervalued or discussed, or the discussion is undervalued of mental health is stigmatized. How can we reach out to populations that are less likely to know about and value using these screening tools, aside from just sharing the website? Do you do outreach?
So that would be more, I think, in line with our advocacy work. Way at the beginning, I didn't go into detail on this because I didn't want to spend everybody's time talking about our agency, but our advocacy work is pretty substantial. We have an annual priority agenda for the state legislative session each year, and during that time we meet with individual legislators and try to educate them on the issues. And so that's the time when we would be able to go into something like that.
Yes, I think it is a wonderful advocacy. And I think the gal that just asked that may email you directly.
Yep, we have a email list for that purpose, and yeah, there's definitely some ways to connect with us and get involved. So I have the crisis line on Oahu. It's 808-832-3100, and on the neighbor islands, you can call 1-800-753-6879. Those numbers and others are available also on our website, on our app, and in our directory. So going back to our last screen, all
So
of our...
somebody was asking about the next success training. Who do they contact locally?
For what training? Oh, the ASSIST training?
Yes.
Prevent Suicide Hawaii Task Force?
Yes. Who is the contact person?
They can call us or email us, and we'll give that to them. That would
Okay.
be technically Janelle. But we can
And-
help them with that.
And by
Oh,
going
Nancy Dealey at the Department of Health. Sorry, that's who it is.
right,
Nancy
Nancy
Dealey.
Dealey at the Department of Health, yes. But that is what you're saying about advocacy, that you want to be one of the hubs on anything related to mental health and mental illness, so you can link them up, and you're worked hard to know the network, correct?
Yes, correct.
Yes.
And we also need to know the needs. So what she brought up about prison reentry, those are the kind of things that we do need to hear from the community in order to recognize a gap and try to do something to fill it.
Right, and I'm sorry, I was answering so many questions. Did you mention your 2 trainings that you're trying to set up on Maui and the Big Island? Because you have a stronger neighbor island presence than some organizations with your office in Maui, and then you're trying to link up. So I do want them to know to contact
Sure.
you, the neighbor island people, to contact you so they can get the announcement for the neighbor island.
Sure. So one of our main trainings, and this is one that was developed in-house with input from local youth and has been evaluated and updated over the course of the last 10 years, and with a very recent update as well. It's called Youth Suicide and Bullying Prevention. The specific title is Ho'olohe Pono, or Listen Well. Our training program coordinator is Amanda. She's amazing. Amanda Martinez, wave your hand. Also a graduate of the UH Manoa Master of Public Health Program, also an advisee of Valerie Yance. Thank you, Valerie. And we're offering a training the trainers, or we call it T for T, in Kahului at the Cameron Center on August 27th and 28th. You can contact us if you're on Maui and you're interested in participating. It's a 2-day training, and then you will be certified to conduct our 2-hour youth suicide and bullying prevention training. We're looking to schedule one on Hawaii Island as well, and we're going to be scheduling some upcoming dates on Oahu. So a good way to keep in touch with us is signing up for our email list. We put all of these announcements out to our listserv, and there's a sign-up sheet in the lobby. You can also email me and we'll add you.
Great.
Just wanted to say,
Hi, Cindy.
I was at the Behavioral Health Alliance meeting at Kahi the other day, and I know they're having training coming up real soon, and there are 12 spaces left. It's only half filled, so you probably know about
Yeah,
that.
we can if
So you
anybody
could
wants
hook up
the details, we have an email we can forward
if you
about
wanted
that.
to take it really soon.
Great. Any more questions? Oh, good. Waking up. Coming up. You have one when I come back? Oh, okay.
I'm not a medical professional. I'm just a mental health consumer. I have a great psychologist who specializes in anxiety and trauma issues like PTSD. If she wanted to make her contact information known on your website, is there a way that she can do that just to serve as a resource?
Yeah, she can definitely get in touch with me. Yeah, I would appreciate that.
Any other questions? Any more linking resources? That's great. Okay, let's give Tricia a big hand of applause and thank you.